Hello and welcome to the SimpleMed Haematology Lecture Series. My name is Dr Marston Hillier and I'm the Haematology Lead. This lecture series will focus on some core topics in haematology, with the first lectures being on haematological malignancies and myelodysplastic syndromes. But first, today's topic will focus on basic blood cell types and why they may proliferate. This is the second lecture in the series. This lecture is aimed at preclinical or Phase 1 medical students and allied health professionals, and so it is pitched at that level. The learning objectives from today's talk are as follows. You will know the typical blood cell lifespans and their proportions in whole blood. We'll identify the main causes of thrombocytosis, erythrocytosis, and leukocytosis, and we'll discuss implications of abnormal blood cell counts in the context of disease. Firstly, let's talk about the proportions of blood cells in the blood. If you were to take a blood sample from a patient and spill it down with a centrifuge, you would see that over half of the sample is a substance called plasma. Plasma represents the water, proteins, electrolytes, and dissolved gases found in blood. A very small proportion will be platelets and white blood cells, around 1% of the sample, and the other half will be red blood cells themselves. We can split the white blood cell component into its subclasses. Most of the white cells in blood are going to be neutrophils, with about 3/4 of them being. The remaining are predominantly lymphocytes, with smaller amounts of monocytes, eosinophils and basophils. Here you can see the importance of neutrophils as the body's acute phase reacting cell due to their number. We'll talk about more of all of these cells and what can happen if we have too many of them in the next slides. Let's talk about blood cell lifespan. Red blood cells have a usual lifespan of approximately 3 to 4 months. As we have discussed previously, they are produced in the bone marrow and destroyed in the spleen. It is relevant to know the lifespan of red blood cells. A commonly utilised laboratory test for the diagnosis and ongoing management of diabetes is the HbA1c blood test. Hemoglobin has the ability to bind other molecules other than just oxygen, although it happens very rarely. One of the molecules that is able to bind to hemoglobin is glucose. As such, we can, at any given time, measure the proportion of hemoglobin that is bound to glucose instead of oxygen. This is a relatively irreversible process, and therefore glucose bound to hemoglobin will remain for the lifespan of the red blood cell. The levels of glucose to hemoglobin binding are proportional to the average serum glucose value over time. Now, if for whatever reason the red blood cell lifespan is lower or longer than we expect, this can affect our interpretation of HbA1c. If red blood cells die quicker than this, then this can lead to an abnormally low HbA1c value, when in actual fact the value should be higher. Alternatively, if red blood cells are living for longer, then this may lead to an artificially high value and overdiagnosis of diabetes. Platelets, on the other hand, only live for 5 to 7 days. Their production is mediated by the hormone thrombopoietin. Abnormal platelet lifespan or function can lead to abnormal bleeding states. Too many platelets can increase your risk of thrombosis, and too few can predispose you to bleeding. We utilise antiplatelet drugs commonly as secondary prevention in prothrombotic states, such as after a myocardial infarction or stroke. Sometimes if platelets are very high, say greater than 1,000, an antiplatelet drug like aspirin may be used to reduce thrombosis risk. Now we're going to talk about white blood cells. The lifespan of white blood cells is very variable, with the shortest lived white blood cell, the activated neutrophil, may only have a lifespan of around 24 hours in tissue before being phagocytosed by macrophages. On the other hand, some memory lymphocytes may have a lifespan of years. The role of these long-lived memory lymphocytes are to allow the body to quickly respond to antigens that it has seen before. This allows for more effective immune clearance. Now we're going to talk about what can happen if you have too many of any of the individual types of blood cell. Firstly, if we recall, red blood cells are produced in a process that is mediated by EPO release from the cells of the macula densa in the kidneys. Kidneys release EPO in response to hypoxia. We can classify the causes of too many red blood cells, also known as polycythemia, into two separate groups. Primary polycythemia represents too many erythrocytes being produced without an appropriate signal from EPO. We'll talk about this again in a moment, but it's nearly always pathological. Alternatively, you can have a physiological reason for having too many red blood cells. This is usually as a result of chronic low blood oxygen levels. A common clinical example of this is in patients with severe COPD. In severe COPD, you have low oxygen saturation. The kidney recognises this and secretes more EPO to increase oxygen delivery to tissues. This is normal, although may be reflective of severe COPD. You may also see a secondary polycythemia in people exposed to high altitudes, where there is a lower partial pressure of oxygen. EPO abuse, such as in athletes, may lead to a polycythemia, where the additional hemoglobin circulating can increase endurance. It is, however, worth bearing in mind that you can have a false polycythemia. If you recall, a laboratory hemoglobin is measured as a concentration, and as such, if there is less fluid in a blood sample, it can artificially increase the hemoglobin concentration. That remains true even if the actual number and amount of hemoglobin is normal. Often, in the absence of a clear cause of polycythemia, common advice is to ensure that a patient is well hydrated and then recheck a full blood count to see if the polycythemia persists, as it may simply be due to dehydration. Haematologists are often interested in one cause of primary polycythemia, otherwise known as polycythemia rubra vera. It's a myeloproliferative disorder where a stem cell precursor to red blood cells suffers a genetic mutation in a gene called JAK2, which codes for a Janus kinase. This causes too many red blood cells to be created. Very high levels of hemoglobin as a result of this condition can predispose to thrombosis or other stereotypical but unpleasant symptoms such as pruritus or itching in hot environments. The treatment for this condition is usually chemotherapy, such as hydroxycarbamide or hydroxyurea. Now we're going to talk about thrombocytosis. Just like polycythemia, we can split the causes of having too many platelets into primary and secondary causes. Primary thrombocytosis, also known as essential thrombocytosis, is another myeloproliferative disorder. Too many platelets are produced from abnormal platelet precursor cells, just like with polycythemia rubra vera. The treatment for this condition is chemotherapy. If the patient has a platelet count of greater than, say, 1,000, then often a prophylactic antiplatelet drug such as aspirin is given. However, the most common cause of thrombocytosis is something called reactive thrombocytosis. This is where the body releases more platelets in circulation in response to stress. That stress may be due to infections, inflammations, drugs, surgery, or any other physiological state that causes the body stress. It usually resolves by itself in a matter of days to short weeks, and no treatment is required. If it persists, then input from a haematologist may be needed. Leukocytosis, or having too many white blood cells, can again be split into primary and secondary causes. Primary leukocytosis is usually referred to being some kind of leukemia, a cancerous condition of white blood cells. Now, you may be wondering if lymphoma is a condition of leukocytosis, given that in lymphoma there are too many lymphocytes. However, the distinction between leukemia and lymphoma is that in lymphoma, lymphocytes are found in lymphatic tissues, such as lymph nodes or in the bone marrow. They are rarely detected in peripheral blood, which is the definition of a leukocytosis. The most common cause of leukocytosis is secondary. In common clinical practice, we use leukocytosis to determine if inflammation is present. An elevated neutrophil count may be suggestive of a bacterial infection, although this is not specific. An elevated lymphocyte count may suggest a viral infection, although this is often delayed and occurs maybe 3 to 5 days into the infection. A monocyte predominant leukocytosis is rare, but can be seen in severe bacterial infections or severe inflammatory states. In this short lecture, we have briefly discussed that white blood cells have a long lifespan, and too many can be a normal response to chronic hypoxia, or alternatively be due to myeloproliferative conditions. And similarly, platelets have a short lifespan, and having too many is usually due to a reactive cause like physiological stress. Too many white blood cells, similarly, are due to reactive causes and rarely leukemias. We haven't covered leukemias today, but in the next series of lectures we're going to start talking about leukemias, lymphomas, and myelomas, so stay tuned for further episodes. That is the end of this lecture. Be sure to check out simplemed.co.uk for hundreds of free articles, thousands of free questions, and any support with questions that you might need. Thank you for listening to this lecture on haematology, and goodbye.